again, everyone, and welcome to another edition of Doc Talk with Monument Health. My name is Mark Houston, and in a small town, everybody knows everybody, and that can make it hard to talk about what's going on inside your head, whether it's stress from work, family burnout, feeling off, not knowing why. It's easy to think, I'm fine, I'll deal with it later. Mm-hmm. But what if fine isn't fine anymore? So today on Doc Talk, we're sitting down with Erin Adkins, a mental health counselor, and Mandi Leite, a psychiatric nurse practitioner at the Lead-Deadwood Clinic, to talk about how mental health care looks in a small community and why taking care of your mind should be as normal as getting a physical. So thank you guys for coming in and doing this all the way down from Lead-Deadwood. Yeah. At least it was a nice drive down today for sure.
Beautiful morning.
Thank you guys both for coming in and doing this. So I guess let's start with this. In a small town, people say, we take care of our own. Lead-Deadwood is a typical example. I mean, both small cities combined often in this phrase. But when it comes to mental health, that can make it hard to reach out, I think. So what's unique about providing and seeking care in a place like Lead and Deadwood?
Well, I think what really is nice is that our services are offered within the clinic. So you can pull up to the clinic and someone might not necessarily know that you're there for a mental health visit or, because you might just be at the pharmacy or you might be just seeing your primary care doctor. So it kind of offers a little bit of, like incognito. We don't know why you're at your appointment.
Okay.
A little anonymity.
Yeah.
Well, and I suppose that really is what people specifically for this type of help are looking for, aren't they? Because that stigma, is it still there?
The stigma's still there. I think it's waning quite a bit, actually. But the difference kind of between our two jobs, although we share a lot, is they're going to come to me and share all the things they're not going to share anywhere else. Mm-hmm. And in a small town, that is a big deal, right? And I always start off with a new client telling them, I live and work here. I have a kid at the high school. You're going to see me around. If that's a problem for you or, then we do need to talk about that. I am the only counselor, therapist in Lead-Deadwood. And so I'm kind of humbled at how the trust is there and those things. And word of mouth is really how this spreads.
Right.
Yeah.
Well, let's talk a little bit about what the difference is in both of your positions. Erin, you're a mental health counselor, and Mandi, you're a psychiatric nurse practitioner. So what is the difference between those two jobs?
Well, so my job, I am, a nurse practitioner that's specialized in mental health.
Okay.
So I can assess, I can diagnose, and I can form a treatment plan. With that plan, we can involve prescription medications if need be. We can also work on more holistic approaches. I like to approach every patient, mind, body, spirit. Comes from the nursing background. We like to we can use medications, we can use, adjustments of do you need to get your sleep routine better? Do we need to focus on nutrition or exercise? And then we can also integrate Erin to do therapy. So those complement each other very nicely.
So Erin, then describe your position too.
Sure. Well, as Mandi said, research supports that the mental health realm is best supported by both medication management and psychotherapy. So I come in at the psychotherapy portion, and so I primarily do things like cognitive behavioral therapy, acceptance commitment therapy. I like to integrate all of those things together, modalities, because most of us don't respond just to one type of therapy. Usually Mandi's just joining us. I've been at the clinic 3 years, and the doctors have been, and other providers have been so accepting. They wanted this position. Actually, they lobbied our administrator to have my position brought back after 5 years. And so they're very supportive. And that means a lot, too, because the client does feel like that whole biopsychosocial model of integrating their whole being is being taken care of. For me, it's what you think of traditional talk therapy, and we integrate the goals of the docs or of Mandi into that. And I get to see the client generally weekly to every 2 weeks and with an hour session, where Mandi and the other docs, once they've formulated that care plan, including medication, every 2 to 6 weeks, they'll check in.
Is it a new thing to have people in your positions working together? Is that something recent, or is that something that's been going on for quite a while?
I think at this clinic it's new.
Okay.
Not every primary care clinic has a position like mine and Erin's, so it is relatively new, I would say. But yeah, I think it's...
Yeah.
Well, it just seems like in a lot of people's minds, you go to a therapist to sit and talk.
Yeah.
Your side of it, I don't think a lot of people consider.
No.
That's something that happens.
No, that they don't realize that we can work on medications while working on therapy. Medications don't have to be long-term, ideally not long-term. We would like to get patients stabilized, and then we can work off taking off some of those medications. If we work through some of the issues or what's going on through therapy.
Right.
Yeah.
Okay.
This is... I want to give a shout out to our administrator at the Lead-Deadwood Clinic, Tracy Matthews. When they interviewed me in 2022, she walked me through the clinic, and I interviewed with the whole panel of providers there. But she told me her goal was to have my position and maybe another therapist position or counselor, and to have a psychiatric mental health nurse practitioner there, and she's making that happen, which is beautiful.
That's awesome,
yeah, because the docs, I would say since COVID, the need was there prior, but COVID really pushed people to ask for this kind of help, and Mandi specializes in these medications, and docs can handle anxiety, depression, even ADHD stuff, but sitting with that client and really understanding the need and then going off or on, this is her specialty.
Yeah.
And so they have been, so happy to have her and offload some of that care to her.
Well,
and
go ahead.
I have more time. I can spend more time with patients. We're not going through a full physical. We can, really evaluate what's going on and take time just to talk about their symptoms.
Okay. And you mentioned some of the things, anxiety and ADHD and things like that. And I think when a lot of folks hear mental health, they think it only applies to depression or major disorders, right? But most of us, you're juggling stress and exhaustion or constant anxiety. So how do you help people recognize when it's time to get help with stuff like that?
I think if you're feeling any of those symptoms, it's better to come in sooner rather than later. We don't need to be in a crisis before we present to get help.
Do most people wait till that happens, though? Or are we getting better with that?
We are getting better with that, and part of that has to do even with the medical model. So I think it was last year or so, it's proposed that every person over 12 years old has either a PHQ-9 for depression questionnaire done, or a GAD-7, which would be for anxiety. The depression is what they watch for above age 9. So when you come in for your annual physical, or the kids come in now for a sports physical, on the sports physical, there's about 4 questions, I think it is, or 5 questions that have to do with mental health.
Is that new?
That started maybe last year or the year before, and it could have been sooner. But even on my kids' physical yesterday, we saw those questions, right? So, and now Medicare for our seniors, they have to get a depression screening annually. That is part of their annual physical check-in. And because we want to watch for these things, when we think about the biopsychosocial model, if we're not doing well, anxiety does what to us? Increases blood pressure, heart rate, breathing rates. That's not good for us. Depression, that has another effect on the body, So, and we choose not to work out, or our sleep is bad.
Or nutrition isn't where it should be.
Okay.
Yeah.
Oh, that's fascinating that this is... I'm so happy to hear that this is kind of being worked into now. Worked into these, if you go to just a physical, like you said, at 12 years old or 13 years old, that these questions are on there.
Yeah.
Do you get a good response to that? Do parents, do they see these things like, oh, great, or like, well, hey, why do you need to know what my kid's mental health is at this point, right?
Yeah.
Do you get some of that?
I feel like most parents, they answer the questions because,
right,
that's what you have to do. So
yeah,
that's.
I think kids actually are, I would say, even middle school, high school, and up are much more open to our process.
Yeah.
Everyone is getting to be more open, but these kids are like, no, I need to talk about this, right? Or I would like to go to that. So at our clinic, we started an opportunity that if someone scores in the medium to high range of depression or anxiety on either of those screenings, the doc formulates a plan with them on how they're going to handle it. So they put in either a referral to me or now to Mandi if they would like to do a medication management of that. that, so that we can track, are these things getting better? So we know, like depression and anxiety, if we screen for that every 6 to 8 weeks using those same questionnaires, if we see a 3-point difference up or down, we're either on the right or wrong track. And that helps us with the patient, like what symptoms, what are we mitigating, what aren't we, where are we missing, what are we doing well? And the docs are really open to that. And that's becoming part of the whole person model of
That's so good to hear, to know that exists now. Because in my time going to the doctor and none of that was ever talked about. You know, you were kind of told to suck it up. You'll be fine, right?
Please don't do that.
Please don't tell kids, anybody that, really.
No.
Well, let's talk a little bit about privacy too, because in the community where you might run into you guys, and you talked a little bit about this, Erin, how do you help patients feel comfortable reaching out without worrying about what other people think?
I think honesty is the best policy. You know, for me, I get people in all the time from kids that go to school with my kiddo, and we talk about that up front. It's really important to me that people know, and I talk about this even with how I work their notes in our system, right? Your privacy is most important to me. If anyone knows you're here, it's because you've let them know. Right. And so, and I say, I'll respond to you how you respond to me in the community. So if you walk by like you've never seen me before in your life, cool, because I'm going to be at the same grocery store, right? But if you give me a head nod or you want to stop and talk, I'll reciprocate. We just won't talk about what we talk about in here because I don't want people asking you, how do you know her?
Right.
But this Lead-Deadwood, I think, is such a great community. I think they've always been help each other, let's help ourselves within our community. And so, again, I'm just humbled at the acceptance of me, again, people knowing me or knowing family, and that they would trust me to hold their confidence and privacy in that way.
Do you kind of feel that same way, Mandi? Same thing?
Well, and I'm not from the community. I'm new to the community, so I think, that also offers... I have the same principles as Erin does, that, I will follow the patient's lead on, how we approach each other when we see each other in public.
So when you're on public right now, a lot of people are still like, well, who is she?
Yeah.
Somebody new or visiting here? Some gambling? I don't know. Well, Mandi, from your perspective as a psychiatric nurse practitioner, how do you approach care then that can combine the therapy and the medication and the overall well-being without making patients feel like they're medicalized?
Yeah.
How do you do that?
So I let the patient take the lead.
Okay.
It's a collaborative approach. I can offer medications, I can offer, brief psychotherapy, but I really let the patient just take the lead on what they want to do. It's their choice. We don't have to do anything. We can think about it. We can continue to track things. But just, I let the patient lead, and it's a collaborative approach. Whether we're working with Erin or our primary care doctors, we're a team, and we're there to help them get the best help that they can get.
Well, Erin, then on the therapy side, what kind of issues are you seeing a lot of right now? Is it still pandemic-related stuff, or is it the political discourse that's happening right now? I mean, what are you seeing? Are those...
all those. Lots of tears have been shed on my couch about both of those things. Yeah, we are still seeing, research tells us now about long-term COVID and the psychological effects. So depression and anxieties. People are still fearful, not necessarily about COVID itself, but they lost a lot of social connections in that time. And that's furthered the distance between people and their people with the political discourse right now. And so we talk about how to talk about those things. It causes a lot of anxiety and depression or isolation. Isolation's a big deal in our rural communities. Loneliness is an epidemic of the senior population that's research based at this time. There's evidence supporting the mental health effects of loneliness. And, I live 10 miles out of Lead and Deadwood, and people live further than that, right?
Yeah,
and
right.
so getting people connected again is also one of my goals. Where are you going to meet people you want to actually be a part of a group? Where do you want to volunteer? Because social connection is so important to the well-being of the mind.
Well, and some people listening to this right now will be like, well, what do you mean? I mean, we're socially connected every day through smartphones and technology, right? I love your reaction to that right there, Erin. How do you feel? I mean, that connection obviously is not the same as face-to-face connection.
Yeah. I mean, it's not, and you know, from our youngest populations to our oldest populations, everyone's using that smartphone and thinking it's a form of social connection. It's not sitting next to someone. It's, you know, I like to talk a lot in my practice, especially with adults, about like intimacy, because intimacy isn't just what we think it is, right? It's being connected, spending time, physical contact, whether it's hugging, it's filling our cups through, you know, friendships and cooking together and that social intimacy, and people just aren't doing it like they used to.
Yeah.
Well, how do you balance that then? I mean, what's the best way to do it? Is it to make yourself get up and go either be where the people are or find friends or family?
Yeah. I mean, I ask my patients all the time, how well do you feel supported in your community? And that's like your physical community. You know, to start by just identifying, like, who are your people?
Yeah.
And how can you connect with them? Or how could you further connect with them or your community?
So if they're struggling with that, what direction do you point them in then at that point? You know, if they don't have that support system that most of us do, then where do they begin or where do they turn?
Yeah. I will encourage them to use the phone if that's their only. I mean, because even, you know, AA groups and things like that are meeting via online. And so if you're rural and that's the only way you can connect, you know, I prefer not to do telehealth because I saw the effects of having to get people back in the office after COVID, and that created a whole nother kind of anxiety. So, you know, I do encourage even my patients who are stuck or not having a strong social connections, you come into the office. You know, because that's getting them out. They're meeting our front desk staff. They're running into people. We're a small town, so they're going to see someone they know and have an experience to remind them. Even connecting then with, you know, we couldn't do our job without our patient access specialist, Jamie. They love talking to her. And so it starts those juices flowing again for people who have, you know, stayed home or have stopped going to church because they can do it via online now. Yeah. And so once they get a little dose of that, I think it encourages them to, oh, maybe I should go back in person to church, or I could call my friend for a coffee. But, you know, it's just hard with the phones. It's not the same connection. And so people who don't have that strong social connection, I start with them from the basics, like, who's your family? And we go from there. Who's your friends? Did you go to church? Do you go to church? You know, that's a place. We have more churches in the Lead-Deadwood area than anywhere else because of all the cultural differences that arrive to mind. But so it's like, find your people and go from there. So
and then use that online component to supplement. You know, like if you can't make it to a AA meeting every day because they're only offered in person certain days of the week, then use that online component just to supplement that connection.
How do you guys handle this when you go home at night after you hear, you know, the stories that you hear? And because my guess is in this profession, the outcomes, the positive outcomes can be uplifting and make you feel good. But what you hear before that outcome happens is not the best in these people's lives. So how do you handle it, Mandi, when you go home?
Yeah, well, I think you got to practice what you preach. You know, like you got to take care of yourself. You got to focus on wellness, exercise, eating right, meditation. You know, people don't believe it unless you actually do it. So you have to and you just have that separation of this is me, that was my patient. I don't absorb I'm there to help them, not take on their problems.
Yeah. Same with you, Erin?
Yeah, self-care. I mean, I went to USD, and from the professors there to the women that I was an intern with at Spearfish Counseling, self-care, just to mitigate your own stressors. I don't know about for Mandi's profession, but ours, they really encourage us to have our own therapist for this exact reason, right? So having that person or monthly or at least quarterly appointments to even just check in and then be held accountable for yourself. Are you doing your self-care? What's going on with you?
We see a lot of the self-care is a big word that's going around. You know, social medias specifically are talking about that and what to do for self-care. But what does that look like for people? Is it individually tailored for kind of each person?
I think so. Yeah, and I don't think it doesn't have to be anything fancy. It doesn't have to be anything expensive. It could be, you know, spending an extra 2 or 3 minutes in the morning to journal, or, you know, to just take time for yourself. Go for a walk outside. Get natural light. eat right. I mean, it doesn't have to be complicated.
Does it come down to the things that and enjoy the things that you specifically are interested in? I mean, that you enjoy doing. Is that part of self-care, whatever that may be? Okay.
Yeah.
Well, how does, kind of going back a little bit to stress and anxiety and the things that you guys see and that you deal with, how does that show up in your body? How does that manifest itself generally?
Yeah, I mean, it can manifest in many ways. You know, a lot of people, their sleep is affected by it, so they're not sleeping well, which then snowballs into their mental health isn't doing well. So it can show up, and everyone's different, so it shows up in a multitude of different ways. People carry the tension, you know, in their body. Physically, they're feeling the tension, or, you know, they're just... everyone shows up a little bit differently, or they feel so down that they can't get off the couch or get out of bed. So everybody just manifests a little bit. It
seems like it would be hard to know between an illness and, you know, depression in some instances, like a physical illness in your body. How do you tell her? When should you know you got to go do something at that point?
Well, I mean, even on the screening, it's specific. In the last 2 weeks, how have you felt about, you know, have you been engaging in your hobbies or things that you normally enjoy? And that's a scale from 0 to 3, meaning not at all, or, you know, I haven't had that problem at all, or I've had it nearly every day for 2 weeks. So, you know, kind of like the cold. If after 2 weeks these symptoms are persisting, you're maybe getting out of bed. You know, we hear a lot too online about like performative depression, or where you can go out, or functioning depression. You can get to work and do the things because you kind of have to, right? And then when you get home, you're just not engaged. We really want to talk about that. If you're not eating or sleeping how you normally would, anxiety shows up different, and I like to talk to my clients about that like a fire alarm. Like your brain's literally giving you a fire alarm of high blood pressure. Maybe you don't normally have high blood pressure, but you've been worrying a lot more, and all of a sudden your doc's like, what's going on here? Here's a medication. Go see Erin. Or, you know, you're constantly reaching for the paper bag because you can't control your breathing. It's time. It's past time to have been in. And so those questions look like, can you control worry? Have you been worrying about more than one thing consistently over 2 weeks? You know, are you moving faster or slower than you normally would? So it does show up differently for each of us, but there are certain cues, especially when the doc or their nurse are going to do a screening that they're going to ask you about. And if those are new for you, let's just talk about it. You know, I see clients anywhere from 2 to 3 sessions to kind of get an assessment and diagnostic thing going, and then they're relieved to understand what's going on with them. And then Mandi or the doc treats them, and especially like ADHD symptoms or something like that. And then they just come in for check-ins once in a while, or they want to work more on executive function skills, those kinds of things, to where trauma and people who have major depressive disorder chronically, we're in there for 12, 18 months just trying to mitigate and learn new ways of being and controlling.
I assume both of you also, are you on social medias at all to one degree or the other? Okay. TikTok has got to be quite possibly the worst for advice of almost any sort. When it comes to not only physical health but mental health as well. Do you guys have 1 or 2 things in particular that you would love to tell people, look, this is such BS. Please stop listening to this.
Yeah.
Is there anything like that comes to mind?
It's much more complicated, and there's more depth to it than just, I saw this on TikTok, or my friend said I have this diagnosis. I think my friend has this. There's many more layers to it.
Yes.
So the self-diagnosis is really not helpful.
Right, exactly.
I mean, it's great that you could come in and talk to someone because you think you've got something going on, but like, you know, and in general, we want to just treat your symptoms. You know, we don't always need to put a label on it. We just want to help you feel better.
That's a good point, yeah. I mean, I'm assuming a lot of people, it almost seems in some instances they want that label so they can go out and say, well, see what I have. But I don't know. Yeah, maybe you don't need that.
Yeah, and sometimes it's helpful because you can relate to what, you know, oh, I do have this going on. But oftentimes I tell my patients, I just want to treat the symptom that's bothering you most first.
Yeah.
And let's get you feeling better. And the diagnosis isn't as big of a deal. I mean, it helps direct my guidance on what kind of medications I will prescribe or what approaches we take, but it doesn't necessarily help us.
The diagnoses in our field are so intertwined.
Yeah.
I mean, sometimes it's like pulling a hair here, and I won't know, so I'm trying to differentiate these, and then Mandi can look at the patient also or meet with the patient and figure something out, because it could be time-oriented that separates these types of diagnoses. It can be one symptom is greater than the other, and that could mean something different from, depression, bipolar, borderline, and these kind of escalate. So, it can be difficult at times. And like Mandi said, we want to treat the symptom. I come in more at let's get to the root cause, right? Like the diagnosis, while it matters to me and how we might talk about things, how is this manifesting for you? Where did this come from?
Well, if someone is listening to the podcast right now and is thinking, I don't know if I really need help, what is the one small step that they could take right now, listening to this, and they're like, well, I've heard a couple of things that relate to what I'm going through. I don't really want to get off the couch. I'm very tired. I have no desire to do the things I used to do. Then what is that first small step they can take right now after hearing what you guys have just said?
I think start by talking to your doctor, your primary care doctor. If you don't have one, maybe get established with care and just talk to them and see if they have something that can help you, or if they need to refer you to someone else, they can. But I think just start by talking to your doctor.
Okay.
Yeah, I mean, and we're open for self-referrals in that sense, but it depends on insurance on whether you can self-refer or see your doctor. So we find it best to just err on the side of caution, contact your primary care doctor, let them know what's going on for you, whether it's in an appointment or my chart or a phone call, and then ask them for a referral to us, and we can help you kind of distinguish and figure out what the need is.
Excellent.
And things.
Well, thank you guys very much for coming in. I appreciate talking with you about this, and I hope, that this does move the needle for certain people, because it's. I'm so happy that mental health and the way we talk about it now is not as stigmatized as it used to be. That people, and like you said, young people specifically. I have a 19-year-old. And he understands that. He knows that you got to talk to somebody. And, it's still hard to say, hey, well, let's set you up with a therapist or let's go see somebody. But at least that line of communication is open and they're not hiding it anymore. I think that makes a big difference.
Absolutely. Yes.
So thank you guys for coming in, for sure. You guys are at the Lead-Deadwood Clinic with Mandi and Health. And anytime you guys want to come in and chat again, let's do it. Appreciate it.
Sounds good. Thanks for having us.